Okay.
Here we go. Hello all. Good to see you.
All right.
Somebody's on a train.
With any background noise when they're joining, just remember to mute if you're able to, just so we can hear everyone.
Why don't I have a picture?
And we'll get started in just a moment, just waiting for people to trickle in. And we have our interpreter here, Kim Sampson, who's going to be interpreting for us all. And John will start us off in a moment.
Hazel, do you want me to share my screen?
Whatever you're more comfortable with. I could share it or you could share it.
Okay, I can share it. Yeah.
Okay.
Okay, I think we should get started. 12:03. Given we have an action-packed agenda for today, and hopefully you can all hear me. I'm John Kelly. Really glad that you're here. Thank you for coming to this next webinar in the series. Just by way of introduction to what we're doing, I'm going to share my screen and just take you through just a little bit about what we're about here. As part of this series, this is a recovery webinar series that is funded by the National Institute of Drug Abuse. It's a part of a initiative, a 5-year initiative to expand the science and the science infrastructure on recovery community centers. So it's a great opportunity. We have our wonderful steering committee, including Dr. Bettina Hoppner, the co-director, along with myself, and we have a number of resources that you can access through the website, including archived videos of all of these webinars. So check them out at a later time, and as well as other kinds of PDFs on studies and different scales. And actually, we're talking about measurement today. So should we hop over to the poll, Hazel?
Can everyone see the poll? It should be on the screen right now. And if you scroll down, you can see the other questions.
And thank you guys for doing these polls. I know we're doing them every time and it seems a little repetitive, but the reason we're doing it is our goal is to bring together multiple stakeholders and to get us all to talk to each other. So this is a way for us to keep track that we actually bring us all together and then to reach out if we're not.
And I'll just give a few more seconds to let most people vote, and then I'll end the poll. Okay, so it looks like almost everyone's voted, so I'm going to end the poll now. And John, you can continue whenever you're ready.
Oh, okay. You're not going to show the results?
We don't show the demographics.
Gotcha. All right. Well, thank you for doing the poll. We really appreciate it. And we have an extra feature today before our speaker. One of the new things we're going to do on these webinars is feature a recovery community center. And I'm delighted that we have Aaron Como with us, who's the manager of Foundation for Recovery in Sparks, Nevada. Aaron, over to you.
All right, thank you. So I do have some peers here, so I'm going to put my mask on, just for safety's sake, for theirs and mine. I appreciate you guys letting me do this. I absolutely love this organization. So Foundation for Recovery started in Las Vegas, Nevada. Let me see if I can get my camera turned around here. All right. So we are up in Sparks, Nevada, which is in the Reno area. We are just a small little recovery community center here. We branched off from the main organization. We're still very much a part of it. So this is our reception area here, minus the receptionist right at the moment. And this is our main room. Hey there, Bob. So this area is just for the peers to come and hang out. One of the things I love best about this place is that it's a safe space for anyone who wants to come in, whether they're looking for recovery or not. We've got snack and coffee stations set up so they can come in and fill themselves up, get warm when it's cold, because we have a lot of cold days here. And as we come in, so this is Mary. She is one of our certified peers, hard at work. And her granddaughter, Mariah, who is here working hard on her schoolwork. Say hi, Miranda. Mary, I think Mary was going to tackle what is the heart and soul of our organization.
So the heart and soul to me of our organization is that we all come from a place of lived experience. So we have a deeper understanding of what our peers are going through, and we handle every situation with compassion and empathy.
There you go. Thank you, Mary. So this Recovery Community Center was founded back in 2019. Again, like I said, we are just a small little building here. We offer one-on-one peer support services, community resource referral. Yes.
I'm having some trouble hearing you, and I think the rest of the audience might be as well.
Oh no. Can you hear me now?
I can hear.
I can hear okay.
I can hear him.
Yeah.
Okay.
Okay. I will continue on because I don't think there's much I could do about it. So I will try my best to speak into the phone here. Again, this community center started in 2019. We offer one-on-one peer support, recovery support services, resource referral for community resources. We hold sober social events. Again, it's just a safe space for any peer that comes in, so we not only cater to the recovery community here and anyone interested in recovery, we also do outreach to the transient population here, and try and bring them in and connect them with resources, and give them any recovery services that they might be interested in as well, and to try and help with that situation here, because we have a large transient population. We also do training. We are one of only 2 organizations that is certified to provide the initial 46-hour peer support certification training towards state certification. We actually have one of those classes going on now.
And as far as,
I don't want to disturb them too much, but they are in the middle of one. Back here, this is our B Corps office. So we have a B Corps grant. And this is Cindy. So B Corps is building communities of recovery, bringing recovery out to the rural areas of Nevada. So this is Cindy. I'll let her tell you a little bit about that.
Hi, everyone, and welcome to Foundation for Recovery, our Sparks Northern Nevada office. Yes, my name is Cindy. I'm a peer support specialist, and I am working under a grant called Building Communities of Recovery. So I go out and do outreach in rural counties throughout Nevada. We have myself stationed here, but I'm out in the field 3 to 4 days a week. We have John in our southern office too, where he covers the territory, and then we have Melissa up north. So what we're doing out in those communities is building communities of people in recovery from many different pathways. We have all recovery meetings. It's an all-inclusive meeting. We also have seeking safety classes, which works with PTSD and addiction recovery. I teach yoga for recovery in those communities, so that's a powerful tool for relapse prevention. And we will be hosting events, live events, sober events, to show people that recovery is possible and to create a sense of community, because we heal in community, not in isolation. So we're super excited with things opening up and to be a part of the solution out in those communities where it's definitely needed. So
Thank you, Cindy. So Cindy brought up a couple of good points. We also host many mutual aid meetings. I'm going to flip myself back around. You have seen most of the community center here. So we do also have a food pantry and clothing closet, as well as interview clothes for anybody who needs it. We do workforce development. We host mutual aid meetings. We rent or donate the space out to any group, recovery related group that wants to use it. And that's about it for us, I think.
Aaron,
Wonderful.
thank you. Thank you so much. It's really so nice to have that visual and the audio along with the visual, though. It's great to have that tour. Thank you for doing that, and really appreciate it.
And thank you so much for giving me the opportunity. I appreciate it.
Well, it's a pleasure. It's a pleasure. And stay tuned. We'll be doing this once a month. So we'll have another one, another feature spotlight on another recovery community center from somewhere around the country. And at this point, I'll hand over to Dr. Bettina Hoepner, who's going to introduce our speaker for today. Thanks, Aaron.
Thanks, John and Erin. That was wonderful, Erin. And this came out of our last meeting where we talked about how little we, clinicians and other places know about the great work that recovery community centers are doing. And we want to use this forum to really highlight that great work. We also are collecting videos, like 3 to 4 minute videos that we will post on our website. So if anybody is looking in their state and wants to know what recovery community centers exist, they can go there and look at your video to kind of get an introduction. So if you would like to be featured there, please do email us and send us your video and we will get it up there. And now, without further ado, I would like to introduce our first speaker. We will have 2 speakers today. Jo will do the lion's share, and then Hannah will add something to it at the end. And our first speaker is Dr. Jo Neale. She is a professor in addictions qualitative research based within the National Addiction Center and working across a biomedical research center at the Institute of Psychiatry, Psychology, and Neuroscience. Jo originally trained as a social worker before focusing on research. In her research, she has focused on homelessness and addiction, and she is engaged in a variety of research topics, but the ones that she'll be speaking about today, which are her current focuses, are the development of patient-reported outcome measures within the addictions and the evaluation of recovery-oriented interventions, which is, of course, what we all care about here. And she has created this wonderful measure of recovery that I personally really love, but we wanted to know what you guys think about the development and if it might be a useful tool for measurement in recovery community centers. So Jo will tell you all about that. Jo, over to you.
Hi, everyone. Right, I'm going to attempt to share my screen. Looks like we're ready. Thank you, everyone. That's such a nice introduction, and I'm so pleased to be here. That's fantastic. So, as Bettina's just mentioned, we're meeting. Why are we meeting? Because I think there's an interest amongst the people here in finding ways or tools or instruments to look at the success or the outcomes of your RCCs, which sound like fantastic innovations. So really what I want to do is talk to you about the SURE tool, as Bettina's mentioned, and then really to throw open whether or not this might be useful for you in measuring recovery in RCCs, or whether there are additional options. And Hannah is going to introduce one of those for us. Now, Erin's very kindly given us a tour, and so I feel a bit guilty that I can't show you around. Originally, the plan had been, I think, that I would come and speak to you in person, so I'm going to have to bring you virtually over to the UK. So welcome everyone, and we are in, this is the Thames, this is London, and you will see here, if you can see my pointer, this is where I am exactly now, which is South London, and this is what it probably would look like if we weren't in a lockdown, but the sun is shining outside, and that's just about 5 minutes away from where I'm speaking to you. So now you can have some context of where I am. Every talk should begin with a few acknowledgements and of course some decorations. I have nothing terrible to declare from my work. The most important thing is to acknowledge all the people here at the bottom and the organisations that have been instrumental in the work I'm presenting. But particularly, I want to mention this group here. These are our Service User Research Group, or SURGE, and they're connected with the Aurora Project. And they're a group of people with personal experience of addiction who help us with all our projects, and particularly those that I'm talking about this afternoon. So I think my session is about 35 minutes, so I'm going to split it, if that's okay. If you'll let me just talk for 20 minutes or so without questions, I can tell you a little bit about SURE and how it was developed. And then we're going to give you a 5 to 10 minute slot where you can try out the measure and also throw out some questions. We can have a bit of discussion. And then I'll come back for 5 minutes and tell you a little bit more about what's happened since we actually published the measure a couple of years ago. And of course, we'll come back to Hannah then. So hopefully this will all in all make it quite an interactive hour that we'll have had. So what is SURE and how has it developed? In order to do this, I've got to begin by telling you a little bit about what a patient-reported outcome measure is. So there's a patient-reported outcome measure here on the slide. And basically, it's a short self-completion questionnaire or assessment scale or rating form. Now, these aren't specific to the addiction field. In fact, I think they were developed in orthopedic surgery. So what they do is they allow people, or they allow clinicians or doctors or providers to assess health status or health-related quality of life, focusing on what it's like from the patient or the client or the service user perspective. So obviously, in order to develop these PROMs, as we call them, you have to do quite a lot of early developmental work with people who actually are experiencing the issue that you're trying to measure, to make sure that you're capturing indicators of that measure that's important to them. Once you've actually got the measure, then have to put it through all of the psychometric testing to make sure it's reliable and robust and rigorous. So these have been around for many years now. And so SURE is actually a PROM. SURE stands for the Substance Use Recovery Evaluator. It is a PROM. It's quick and easy to complete, we hope. We developed it with a lot of collaboration with people who are in recovery, and it is used to help people measure recovery from dependence on alcohol and other drugs. Because we developed it with a lot of input from people who are using substances and in recovery, it has good face and content validity. By that we mean people seem to think it actually does measure recovery quite well. We've also put it through the psychometric testing. It's just 21 questions, and you'll see it later on. And you can use it in addition to or instead of other outcome measures. So the question, I suppose, is why did we bother developing it? And I want you to take you back now to 2013 in the UK, where we were using the term recovery an awful lot. But there was a lot of debate, and it was getting quite heated about what it actually meant. So some people were saying it meant abstinence, and other people were saying, no, it was broader than abstinence. It's about harm reduction, it's about well-being, it's about quality of life. So we were getting ourselves in a bit of a stew about what exactly it was. But at the same time, we were saying that services had to demonstrate that people using them were actually in recovery. So like, how were people going to actually assess what treatment services were doing if there was no way of measuring recovery? So that's where the idea came from. We thought we would develop a study that would produce a patient-reported outcome measure of recovery from alcohol and other drugs. We got a team together The team was quite broad. It included psychiatrists, psychologists, sociologists, statisticians, and of course, critically, again, this group, our service user research group, who are our partners in the process, who talked us through and went with us at every single stage, guiding us and advising us and working with us. It's funded by the NIHR Moseley Biomedical Research Centre for Mental Health. And apart from being a complete mouthful, that won't mean anything to anybody, except it's basically public funded money. So it wasn't industry funded at all. It's basically NHS funding, health funding. We didn't rush. It took us 3 years. And I'll explain a little bit more about what we did in those 3 years in a minute. So again, I'm not going to blind you with sort of boring science, but what I do want to get across is that we did really take quite a lot of effort and took a lot of stages to develop the measure. So it's got 6 stages here. I'm not going to go into these in a great deal of depth, except for the first 2, because I think these might be a little bit more interesting to you. So we've got 6 stages, and again, our service user research group working with us on every single stage. So we started off stage 1, and we thought, right, where are we going to start? So we thought it'd be a good idea to ask people who are quite senior in the field that if they were going to measure recovery, how did they think we should measure it? What recovery indicators were important? So we asked addiction psychiatrists and senior staff from rehab and inpatient detox units to give us indicators of recovery. And we got them to identify them, and then we got them to rank them in a sort of 3-stage process, at the end of which we ended up with 76 indicators of recovery that broadly divided into 15 broad categories or areas. There was quite a lot of consistency across the broad areas, but there was quite a lot of disagreement on particular indicators, with some people saying a certain indicator was very important and some people saying it was totally unimportant. So this is the sort of slide that academics love, that is totally useless because I doubt anybody can read anything on it, but it gave me great satisfaction to put it together. So rather than make you strain your eyes, let me just flag some important things. So the indicators that professionals identified, there were 15 broad categories. So we've got substance use, treatment and support, psychological health, physical health, use of time, education, training and employment, income, housing, relationships, social functioning, offending and antisocial behaviour, well-being, identity, self-awareness, goals, aspirations, and spirituality. So this is where the problems start. Practicing harm reduction. They couldn't, the professionals struggled to agree on this because of course they slipped into the, is it harm reduction? Is it abstinence? Then they started to debate whether or not treatment or support was necessary. Could you be in recovery without accessing services? Then they talked about, employment. Was it fair to have a measure of employment? Because what if people couldn't get jobs because of the employment situation? Then they talked a lot about spirituality, and they couldn't agree on this. Like, was this really relevant? Was it essential? The other indicators as well, surprisingly, even things that seem quite useful, the more we started to look, became quite problematic. Offending and so antisocial behaviour became an issue. Confidence, coping, control, and safe belief became an issue. We got questions over attainment of hope, shame and guilt, appearance, decreasing debts, improved relationships with family, stigma, trust, independence. I mean, I think basically what I'm saying is we started off with 76 indicators, and increasingly they all started to give us a headache. What we did was, in the second stage, we did the most obvious thing, which is we took these 76 indicators to people who were using substances or in recovery, and we said to them, okay, guys, what do you think of these indicators of recovery? What do you think of them? And they basically started to take them apart. They started to be really quite critical. They said things like, hang on a minute, you're expecting us to be superhuman here. You're saying, don't break the law, don't get into debt, don't have negative relationships, don't be dependent on people. And everybody, you know, everybody has a parking fine or a speeding fine or at some point in their time. You know, everybody depends on somebody. So you're asking impossible of us. You've got indicators in here like, you know, feeling confident, feeling self-control, being, you know, experiencing self-belief. Now these are positive, but actually they can be negative, because if you don't have a little bit of self-doubt in your recovery, you get complacent, and that's when you might fall and relapse. So there's a bit of a problem even with your positive outcomes. You've also got outcomes in here that are really, you know, they don't really capture what recovery is. Recovery is hard work, and just saying being positive or being hopeful, that's not really capturing the work that's involved in recovery. Then we're back to, you've got contradictory things in here. You're saying being independent, and then you're saying seek support. You're saying abstinence, and then you're saying harm reduction. Then you're not even recognizing that people are very different. So some people, it might be important to have family or friends or employment, and for other people, it won't. And also, you're not realizing how hard it is for some people. You know, you're saying just things like having trusting relationships with family. Some people don't have family that they can have trusting relationships with. You're saying, you know, eat a good diet, but some people just don't have any food. So you're not really appreciating how difficult this process is for us. And at the same time, you're almost implicitly accusing us things that don't apply to everybody. Like, we haven't all committed crime. We don't all behave immorally. You know, we don't all experience stigma. So be careful you don't attribute feelings and behaviors to us that don't exist. And then I think the clincher, really, they said, look, you've got the language all wrong. You know, you're using words and terms here that, you know, we don't even understand. You know, you've been very vague. What do you mean by abstinence? What do you mean by behaving morally? So they really did quite a hatchet job on these 76 indicators that sent us back to the drawing board a little bit to work out how we could actually delete some, amend the wording on some, merge some together. So we did that, and we ended up with 33 indicators after ditching a load and rewording a load. And then we took them back to 2 more panels of current people who are currently in treatment or using, and people who'd recently completed their treatment or had stopped using. And they seemed to think that these 33 indicators were getting a bit closer. And they said 30 of them seemed, yeah, they seemed like they were looking better. So we then mocked up our problem, our draft measure, and we asked 8 people to go through it in a lot of detail. We amended it again. We then asked another 40 people to complete it and to tell us what they thought, everything from the language to the layout, the response options, and we revised it again. And at the end of that, we had this draft prom that was 30 questions, 30 indicators. We then did the psychometric testing. I won't go to the details of that, but it was basically face-to-face and online. We had 461 people completing it face-to-face, 114 online. And then we got our wonderful statisticians involved, and they did the statistics on it to make sure that we had a good, basically, underlying factor structure and that it was reliable and robust. So the measure that we ended up with has 21 indicators of recovery that are spread across 5 dimensions of recovery, and each question scores 1 to 3. So you can score 21 to 63. That's all probably very, very vague. So what we will do in a minute is have a look at it. But to give you an indication, look, these are the 5 factors: substance use, self-care, relationships, material resources, outlook on life, and the 21 questions, which I'm hoping you'll have a look at in a minute to yourselves. It's set out very simplistically. This is a copy of the paper version. So we do also have online versions. And the idea is that somebody in recovery would complete it for themselves. A professional could help someone complete it. They might want to read out the questions, but what's really critical is nobody should ever complete it for anyone else. And the measure should ideally be completed fairly regularly, every week or 2 weeks, and then people could track their journey and see how it's progressing. So it is quite a simple process. Mel, who's a member of our service user group, very kindly has done a YouTube video for us, if anybody wants to actually see it in action. And that really basically sums up the development of it. So I think that's probably been just under 20 minutes, which now gives you an opportunity to have a look at it yourselves. So we had quite a lot of discussion about the best way of doing this, and decided that what we will do is, using the chat function, we'll drop a PDF version into the chat so you can actually have a look at it. And we'll also drop a link to the online version, or one of the online versions, so that you can actually try completing it yourself. The online version is a little bit rudimentary, and I'm hoping it won't crash if lots of people try using it, but we can give it a go. You can complete it, and then whilst we're talking, I think we're going to have a little bit of help, and somebody will monitor the chat and field questions for 5 or 10 minutes. And then I'll come back and finish off with another 8-minute session, if that suits everyone.
And I just sent the link in PDF in the chat, so everyone can go take a look there if they want.
Shall I pause my sharing screen so people can?
I think it's up to you. I think it should be fine.
And feel also free to unmute yourselves and make comments in the chat. I mean, in the audible chat, not just in the chat box. So Laurie, there is a link. If you click on the chat box down below, there is a file listed there called Sure Copyright. And there we go. Hazel kindly already spelled it out. And if you click on that, it'll download a PDF file to your computer that you can then open and complete the measure. And there's also a link here you could do where you can go through the sections in an online format.
Can you also email these links to us so that we can have them in our files as well?
Absolutely.
They're also on our website right now too. So we'll upload everything mentioned in this presentation onto our website.
Bettina, may I ask a question of Jo?
Of course, please do.
Yeah. Hey everyone, this is Brandon Bergman from the Recovery Research Institute as well in Boston, Mass. Jo, I had Dr. Neale, sorry. I had a quick question about the kind of the ordering of the groups. Do you feel like, in terms of wondering if you've given a thought, and I imagine you have, what the implications are of starting with the professionals and then moving to those with lived experience versus doing that in the reverse?
That's such a fantastic question, and I've been rumbled here because starting with the professionals, if I'm honest, was an accident. Okay, so let me tell you how this came about. We were supposed to start with the focus groups, and there was a delay whilst we got ethical approval. So we were looking for something proactive to do whilst we started. So we did the Delphi group with the professionals just as a stopgap filler, but because by the time they'd finished with 76 indicators, what we did was we also said in the focus groups that you can add other indicators in. You don't have to just use this one. So some other indicators were added in, but it is a slight flaw in the process that was accidental. But it didn't seem to stop in the end. It just made it more interesting to get the kind of critical feedback. And I think it helped people to hone down on what was problematic with people's assumptions about what recovery was.
Yeah, I mean, and the stark differences between how professionals may see recovery and those, and there's some overlap here, obviously, but professionals versus those with lived experience, and the differences in perception of the process.
Yeah, absolutely.
Thank you.
There's a question here about ceiling effects, which is also I can probably answer as well, because I'll answer it in two ways, because it is a great question and it's been a concern of mine, because in a way there is no there's nowhere to go once you're stable and having things are getting together. So we developed it, I suppose, starting with people who were we had a lot of input from people who were homeless. And we had a lot of input from people who were using a lot of drugs at the time. And the idea was that it would actually show the direction of travel. The psychometrics didn't show any ceiling effects, as I'm aware of. But I actually wonder whether or not over time there will be evidence of ceiling effects. And to be honest, I don't actually see that necessarily as a problem in terms of the concept of recovery, because at the end of the day, you want to get to a point where you're stable. I mean, my own health and well-being doesn't increase incrementally every week. I've probably got to a point where I've plateaued. So I guess, yes, there could well be ceiling effects, but I don't necessarily see that as a problem. I think what would be a problem if people started to dip and their scores started to drop.
Great. And there's also a question here about the copyright and if people, clinicians, for example, are allowed to use it.
Yep, so the copyright is actually on the back of the measure. We are very, very keen that people just use it, so there's no charge for it. In terms of the copyright, there are two issues. One is that people reproduce it faithfully so that they don't actually start messing around with it and upset the kind of factor structure and the layout. One of the things that people have started to do is put it into electronic format. And again, if people do that, we'd like to see it just to make sure it's set out and laid out the correct way. There's no charge. If you are a private sector organisation and you're working for profit, then you do have to run it by the King's licensing people, because they will probably want to charge for a private sector licence. But public sector, there is no charge, but all of the instructions and the contacts are on the back of the PDF measure.
And just to clarify, I mentioned clinicians, but not researchers. And if RCCs want to use those themselves, they can as well, right?
Yeah.
Then,
yeah, absolutely.
And Lauren raised a question about the ideal intervals. I think you mentioned something about when you're doing it for yourself, doing it every week or every 2 weeks. What about for if you want to evaluate an RCC and how people are progressing there? What are your thoughts about how often this should be done?
So the only criterion here is not to do it more than once a week, because if you do it more than once a week, it's like jumping on a weighing scales every 2 minutes. You just simply won't see any difference. So the questions are all about your experiences in the last week. So you really need to leave it a week in order to see any change. But it doesn't matter how often you complete it, as long as it isn't really less, it isn't less than a week. For RCCs, again, for services, they might want to complete it when somebody just enters treatment, and then, kind of midway through, once they leave, to follow up. So you don't have to do it repeatedly. One of the things that we always hoped, and seemed to be the case, is that because we developed it with people and they found it quite an engaging measure, it tended to spark discussions about the items that are in the measure. So again, people might find that it's not just an outcome measure, but it's quite good for starting discussion. So it has a sort of slightly therapeutic side to it, which you might find is useful if you're using it with people who are using services, just to better understand their experiences and get them to open up and tell you what is working and what isn't working for them at the moment.
And don't want to interrupt, but I think it's time for us to move to the next section. Is that okay with everybody?
And let's make sure we get back to Sierra's and Deb's and Laurie's question at the end. They're interrelated, and we'll definitely circle back to them because those are great questions.
Excellent. I'm just trying to move the slide on. Here we go. So let me just give you a quick summary of what's happened since we developed SURE. So what we kind of thought would happen is that we thought that people in recovery might want to use it to monitor and reflect on their own recovery. And we hope that clinicians and workers would use it, as I just mentioned there, to start discussions about recovery, to give people words and ideas that would help them to discuss what was going on for them. And we also hope that researchers would use it when designing and implementing treatment and recovery focused interventions. So that was kind of what we hoped was going to happen. In actual fact, we were ourselves a little bit surprised about how widely it was used. And this was probably because there wasn't another comparable measure really at the moment. And also I think because it's one of the few measures that really has worked quite extensively with people who are using substances and its development. So we got a lot of national and international interest. And it was also adopted by ICHOM, which is the International Consortium for Health Outcomes Measurement in their standard addiction set, which was quite good, because that means it's sort of recommended by them to be used along with other outcome measures. As I kind of alluded to when I was answering the questions, we've had a lot of questions from people who are interested in integrating it within their routine treatment and monitoring systems, which is absolutely fine. We just asked if you're putting it into an electronic system, you contact us to check it's set out properly. And if you're a private organisation, you contact us about the licensing. We got interest in international translations, and we also got researchers wanting to use it to assess outcomes from new psychosocial treatments and pharmacological interventions. This is kind of where we're at now. So you see we've got some translations, we've got quite a lot of international use, and also use from the US across the States. We also started to get requests for an app, and that was again from people with personal experience of addiction and recovery saying, okay, you've got this measure, could you not put it in an app for us? And then we can complete it ourselves. So that's what we did. We managed to get some funding, and we produced an app a lot, again, using the same collaborative measures, collaborative methods. So we worked with people who were using substances in treatment and recovery to develop an app that would help them track and monitor their own recovery journeys. And it could help them potentially recognize when they might need help, you know, if their scores were slipping, where they needing to get back in contact with services, and to find sources of support and find inspiration from others in recovery. And we also hope that it would help us to generate some new data to better understand recovery. So we do actually have an app. The app's called Sure Recovery. It's got 6 main features. So if you download it and use it, you can track your recovery. You get a graph, you get some feedback, you get your score. It's got other features, like it's got a sleep tracker, because people told recovery, so you can find out about sleep and track your sleep. It's got a diary function if you want to just record your personal thoughts. The artwork feature, so the banner here is actually artwork by people in recovery, and if you want to submit your artwork to us, we can put that in the banner of the app, which rotates. We've got an naloxone feature, again indicating that this is not just an abstinence focus measure, it's got harm reduction built in. So there's a video on naloxone and information sources on naloxone, and also reading and additional materials. I do believe that if you are quick and you point your screen, your phone camera at the screen, you should be able to use the link there to get it straight away. But if not, and you've got an Android phone, just go to Google Play, or an Apple phone, go to the App Store and search for Sure Recovery, and you can download it. And obviously, again, that's also free for you to use. We've also started to build up a few more resources. So we started with a website, and then we were quite keen on getting a sort of community together around not just the measure, but particularly the app. So we have a Twitter account and a Facebook account and an Instagram account, and some YouTube videos where there's some screenshots there from at the bottom from some of the YouTube videos. There's an email address if you want to contact us. And particularly, we've just started to try and get together a network across England where we've got, you know, local people, local champions. So people who are in recovery, who kind of like the look of the app, who think it might be useful in their networks. And they are quite keen on sharing the app with other people in their networks, and perhaps providing people with a bit of support in downloading and getting up and running with the app. So this is something we just started in England. Of course, again, if you're interested, please do drop us an email, and we will be looking and very welcoming of anybody who's on this call now, or who knows anybody who might like to join us. Those are obviously the references. I think the slides will be available, so again, you don't have to read that slide now. Technically, this is where we fly back to the States, because I think Hannah is over possibly in New Mexico, so we can leave London. There's my contact details at the bottom, and I'll be around for any more questions at the end as well once Hannah has spoken. Thanks very much, everyone.
Wonderful. And Jo, there's a couple of questions in the chat, and we'll get to them right after Hannah. So the reason I asked Hannah to come here, Hannah is a graduate student at the University of New Mexico, and Hannah is very interested in flourishing. And I don't know, Hazel, do you have the slide up where we compare Joanne's and Leanne Cascuda's recovery elements?
Yes, I will just share my screen right now.
So Jo just covered, you know, the kinds of factors that we have on her scale, and in the United States, we've also had a number of scientists look sort of at the elements of recovery, and and you can see them here at the bottom. And the thing that that we're also really thinking about is flourishing and quality of life and those kinds of issues, which are captured on the shore. But we were wondering to what degree we should be assessing them even in more detail or with a greater focus. And Hannah will show you another scale, which is not developed within recovery, but just in terms of psychology for flourishing, and show you what that looks like. Hannah?
Hi, everyone. Thanks for the introduction, Bettina. Let me just share my screen here. Sec. Okay, can you all see that?
Yes, we can.
Great. Awesome. So yeah, like Bettina said, I'm going to talk a bit about human flourishing, which is this sort of all-encompassing construct in the field of positive psychology. There are a couple of quotes here that kind of help better define flourishing, like it, moves beyond the confines of simple happiness or well-being. It offers a holistic perspective on being well. Flourishing is the experience of life going well and a combination of feeling good and functioning effectively. So it's kind of a whole lot more than just, happiness or well-being. It's like all of that plus optimal functioning across these domains. And this theorized model, the PERMA model, says that these 5 areas have to be working well and be fulfilled in order to achieve human flourishing. And these 5 domains are positive emotions, engagement, relationships, meaning, and accomplishments. And so I've just included some examples of constructs that might fall into these 5 domains. So happiness and optimism might fall into the positive emotions category. Flow, which is this idea of how involved and present one can be when they're engaged in a given activity, that might fall under the engagement category. Social support and connectedness, like social connectedness, might fall under the relationships domain. Spirituality or religiosity might fall under the meaning domain, and goal setting or goal achievement might fall under the accomplishments category. And only in 2016 was a measure actually created that captures these 5 domains of PERMA, like Bettina mentioned. It's called the PERMA Profiler. And it was developed and refined with an N of 7,000 across 3 samples, and then demonstrated some strong psychometrics in an N about 32,000 across 8 samples. And these were super diverse samples like Amazon MTurk, workers for an online company, participants in a positive psychology compassion-oriented research study. And it's also been validated in several languages, demonstrates some cross-cultural psychometric strength as well. So it's been used really broadly. And here you'll just see it's used really widely. Like I said, a Google Scholar search yields about 790 results, and it was only developed in 2016. So this is a newer study from just about under a month ago, but this is the only study to my knowledge that uses the PERMA Profiler in any sort of recovery sample. So I do a lot of research in alcohol use disorder, so that's kind of like where my focus is. But this study, it was an online survey. It aimed to capture scores of flourishing between 3 samples, so an alcohol recovery sample, a normative community sample, and then a sample of mental health service users. And these folks were mostly utilizing services for anxiety, depression, or suicidality. And they found that the recovery sample actually scored higher than the mental health sample with a medium effect size, but lower than the normative community sample with a larger effect size. And these effects were seen across all 5 domains of PERMA. And while this is the first, study to my knowledge that administers the PERMA Profiler to any recovery sample, it's definitely worth further exploring, because positive psychology and addiction are kind of like separated, and a lot of folks advocate that we should combine them. There should be more overlap, and I think flourishing is a cool place to start with that, given that it's kind of this all-encompassing positive psychology construct. And that is all I have. I just wanted to briefly introduce that to you all.
Thanks, Hannah.
Is it okay if I share our final poll now? Tina and John, everybody else?
Yeah.
This poll is going to be asking about people's opinions about recovery measures. So it should be up on your screen now. There are 2 questions. The first, you can choose as many as you want, and the second, you just choose one. So you can just submit your results whenever you're ready. Obviously optional, of course. And I'll share these results this time so we can all take a look at them together. And half of the people have voted, so I'll just give us a little bit more time and then I'll share the results.
Oh, and I was totally muted. But Joe, I was going to draw your attention back to some questions we had in the chat earlier. We had Laurie, Deb, and Sierra who had questions that are somewhat related. And Laurie asked about the recovery capital scale and a viewer measure can be used together with that. And Deb asked, how exactly would you use the SURE to demonstrate the effectiveness of an RCC? And then Sierra went into further detail and said, oftentimes you see an initial dip as people are gaining a more realistic self-assessment of where they're at in their lives. And if that's something that you've taken into consideration in developing the SURE and how it should be used. And please, Laurie, Deb, and Sierra, please jump in and correct me if I'm not capturing the spirit of your question well.
And I'm just going to share the poll results now because I think almost everyone has voted.
Very cool. So it looks like so the flourishing part has the least sort of priority rating, and looking after yourself physically and mentally is the thing that we think as a group as the most important one here, or agree most on. And that it also comes out when we look at the second part in terms of what is the most important factor. Great. Thank you, guys.
Tina, do you want to, you'll have to, everybody will have to remember it's 5 o'clock on a Friday here, so my memory may be fading, but I can remember the first question was about the addiction recovery capital scale, which actually, interestingly, when we did our psychometric testing, it's one of 2 other measures that we use to cross-check. So we assumed that if people did well on the ARC, they would also do well on SURE. And in fact, they did. So the 2 scores, I mean, if you do well on one, you will do well on the other, but they're measuring slightly different constructs, because obviously recovery capital is something you bring to your recovery, whereas a recovery score is more of an outcome measure. So you could use them together. You might find that there's quite a lot of overlap and you don't need both of them. You might find that you prefer one, the wording on one over the other. But essentially they are measuring slightly different things, but very, very similar things.
So what about the realistic self-assessment part? So if somebody walks through the door of an RCC and they're now really starting on their recovery journey and they do this kind of measure, would you expect to see an initial dip on the SURE in terms of getting, being confronted with a more realistic self-assessment, or how would you expect that to go?
I think it's like any baseline measures. You want a couple of measures, first of all, just to make sure you got it settled so that you've got the baseline, and then you take it from there. So yes, I wouldn't be surprised if there's a little bit of a fluctuation initially before things start to improve. Was there a third part to that question, Bettina?
Yeah, I think most of the parts together, I think I got them right. Please jump in if I didn't. There's also some questions, people were taking it and sharing their scores. And I think you mentioned it earlier. At what point so, you know, if you're several years into your recovery, would you be expecting to be always scoring at the highest end? Did you look at that, like length of recovery and your score over time?
Yeah, we didn't actually look over time because we didn't have any longitudinal work in the development.
Sure.
But in terms of you know, people who were sort of homeless, experiencing.
So who is Amir?
So Amir is one of the first people that I met.
Could you just mute yourself, please, if you're not asking a question? Thanks.
So people who were employment and clearly had all the hallmarks, if you like, of having been in established and stable for some time, scored better. So I mean, obviously, I've completed it myself on a few times, and I don't ever hit the top score, but you know, I bounce around late 50s, around about the 60 mark. If I got 63, I'd be very surprised. But if I went below 55, I'd be a bit worried.
Perfect. And then there's a question here about using this in young adults. Is it valid and reliable in young adults? Have you tested, or do you know, or what do you suspect?
I didn't capture the question, Bettina.
Is this measure good for young adults?
There's an echo.
I can just read it. Oh, it seems there's an echo.
Here, I'll read it.
The question was, is it validated on young adults, or would it be useful for young adults?
I mean, Noah was wondering in particular whether it might be useful in collegiate recovery programs or you know, recovery high schools, those kinds of settings with youth and young adults in recovery.
Yeah,
Thank you, Noah, for the question.
Yeah, that makes sense. So our sample that we tested it and developed it with were all over 18. So we didn't do any validation work with people younger than 18. We are aware of at least one university in the UK using it. So it does obviously have appeal for younger people, but not below 18.
And then there's a question here about if peers and clients use the SURE app, is there a way for the RCC to get the data, of course, with permission from those peers who are using them?
Yeah, that's interesting and also quite frustrating because we can't actually do that, because what happens is that people sign up, that you know, they consent to sign up, the data is anonymized, and what we get out the back end of the app is more anonymized data that we can't attribute to particular services. And because people are using it and it's all of the data is going into one content management system, we can't actually do that. It would be something that would be worth considering going forward so that we could make it, you know, for example, if a client group had an email address that was recognizable to that service, then it would be easier to find their data in the back end of the app. But at the moment, everybody's data goes into one section, so it's not possible to segregate it.
Well, I hate to cut this off, but we can, if you want to stick around, you can. It's been a wonderful conversation. I'm just sorry that we can't have another hour to talk more about this. But I want to thank Dr. Neale, especially Jo Neale, for coming and doing this for us today, and also Hannah Carlon from University of New Mexico. Thank you both so much. It's just great to see this measurement of the construct of recovery really coming to fruition. And thanks for all your work, Jo. Tune in next time for next May. I think this coming May we have the next one in the series, which I believe I'm giving. Is that right? On the data on recovery community centers. So some of the science on recovery community centers. So hope to see you all then. And thanks everybody for coming. And thank you again, Dr. Neale and the emerging Dr. Carlon.
Thank you, everyone.
Thank you, guys. And thank you for those great questions, everybody. Greatly appreciate it. And Hazel, if you could stop our recording.